The following podcast is part of a certified educational activity titled Altering the Natural History of Spinal Muscular Atrophy, a compelling story highlighting the critical role of presymptomatic treatment. Access the entire activity and complete the post-test at peerview.com/SDE860. Downloadable slides and practice aids are also available.
Spinal muscular atrophy is a genetic condition that is inherited in autosomic recessive manner. It's caused by affection of the survival motor neuron gene that causes damage of the anterior horn cell and the motor nuclei in the brainstem. It has an incidence of 1 in 6,000 to 1 in 10,000 live births and a carrier frequency of 1 in 40 to 1 in 50 people. The main gene affected is the SMN1 gene. In our body, humans have a duplication of this gene. So we have an SMN1 and we have an SMN2. SMN1 produces 100% of the protein that we need for that anterior horn cell to be alive and for that nerve and muscle to develop. The SMN2 is a backup gene, so we really don't depend on this gene. The problem is with patients with spinal muscular atrophy, your SMN1 gene is deleted. It's not there. So the patients are really depending on the backup copy. Depending on how many copies they have, it tells you how strong they are going to be. So a patient with 2 copies is likely going to be very weak. A patient with 3, 4 copies are going to be a little bit stronger, but it's never going to be enough to have the full protein levels that are necessary for your development, to have normal nerves and normal muscles. The way we classify the disease is 1, the time of symptom onset, and the second one is how much motor function these patients can achieve. At the same time, this correlates really well with the copy number. So there are 5 types of SMA. Number 1 is type 0. Type 0 is a prenatal onset. So these are babies that are born extremely, extremely weak from the beginning. They will have difficulties feeding, they will have difficulties breathing, requiring intubation really quick after they are born. Life expectancy is definitely less than 6 months. My experience has been usually less than 2 months, actually. And their copy number is going to be around 1 copy. That's why they are extremely weak. Type 1 are patients that are less than 6 months of age, and they will have 2 copies of SMN2. So these patients present less than 6 months of age. The first symptoms that you're going to see are difficulties breathing, difficulties feeding, and progressively decreased movement in the extremities. These babies are extremely alert, awake, beautiful, looking around, but their body is really hypotonic. Their body is really weak. Type 2 are the ones we call the seeders. These patients start between 6 to 18 months of age when they start having symptoms. And we call it seeders because that's where they get in terms of motor milestones. They will never be able to stand up. They will never be able to walk. Their life expectancy is usually between 10 to 40 years of age. Type 3, it's patients that are older than 18 months of age. These patients, we call it the walkers. They will be able to walk independently. But at some point, they will lose that ambulation. And that's why it's so important to understand that it's not the fact that you're able to get to that motor milestone. The problem is that you're going to start losing those motor milestones with time. And the last type is the type 4, and it's for usually patients older. I would say definitely the time of recognition is around 20 to 30 years of age. And these patients live into the adulthood. They have 4 copies, and that's why they are stronger. So in general, for these patients, the clinical manifestations depend on the severity of the condition. But if I have to say what is common for all of them, you have low muscle tone, you have muscle weakness, muscle atrophy. So how do we diagnose these patients? If there is any suspicion of spinal muscular atrophy, could it be because we have these findings in clinical examination, or could be because there is somebody who has in the family has had patients with spinal muscular atrophy? But the first test that we sent is analysis of the SMN1 gene. The analysis of the SMN1 gene, what we're looking for is 95% of the patients will have an homozygous deletion of this gene. 5% of them may not have a deletion, and that's where we have to order more testing that is sequenced to try to find maybe a defect like a point mutation or something like that that is associated with a deletion and is causing the spinal muscular atrophy. Again, 95% will be deletion, but then you have 5% that could be something more, a smaller defect that is causing the condition. If you have 2 copies of SMN1, you really don't have spinal muscular atrophy. Something that is also important is to get the copy of SMN2 gene. Why is important? Because we now have to look at insurance approval. We have opportunities for research. It's also going to give you a good prognosis or saying how strong this patient is going to be. So what is one of the difficulties that we have in terms of the diagnosis is the delay in diagnosis. And why? Because there is so many differential, right? There are so many differential diagnoses that can be included that make the diagnosis of this patient more complicated. SMA type 1 patient, because they present with hypotonia, weakness, feeding difficulties, and breathing difficulties earlier in life, less than 6 months of age, those patients may get diagnosed within 3 to 4 months of the onset of the symptoms. The problem is if you look at a type 2, we're talking about an average of 15 months for diagnosis and an average of 40 months for a patient with type 3. Newborn screening was approved at national level in the United States in 2018. Each state has the decision to implement it to the newborn screening right away or not. There are only 12 states right now that can screen universally for SMA, but the other states are still in the process to try to get it implemented. The ideal situation will be for us to diagnose these patients very, very early in life. So the recommendations right now is that in terms of genetic testing is to screen every woman who is considering to be pregnant. If that person is positive or is a carrier, then obviously we will have to recommend to check if the father is a carrier. If that is the case, the chances of 25% of chance to have a kid with spinal muscular atrophy. If there is a family member who is affected or is affected with spinal muscular atrophy, we really recommend also to test that couple, probably also test that child that we may have a question about. I have one family who actually the diagnosis was made through the mom's pregnancy. She was tested for carrier for SMA and she was found to be positive as a carrier. Then they test father was also positive. That baby was negative, but then they realized that their 15-month-old daughter was hypotonic and was weak, and it was likely because of spinal muscular atrophy, and that was the diagnosis. So that is the importance of doing it before pregnancy. Some parents, even though they know that they have had family members with spinal muscular atrophy, they don't want to do it. They don't want to do amniocentesis. They don't want to do anything else. They just want to wait until the baby's born, and then they will test the baby. Testing it can be sent today really fast. The results come back fast. There is one stat test can be back in 48 hours. And there is the other one that is usually between 5 to 10 days. Anyway, compared to before where we had to wait months, it's extremely, extremely fast and easy to get. I would like to share with you a case from my clinic. This is Millie. This is a little baby, a 1-day-old girl, born at 40 weeks gestation by C-section, just because repeat C-section. She has an older sister who I diagnosed with spinal muscular atrophy type 1 and is currently trach and vent dependent. Mother didn't want to have amniocentesis done during this pregnancy. Usually we do it at 14 weeks of gestation, but she said, I'm not going to change my decision. So even knowing if she had it or not. And there is always a risk of losing pregnancy, so she didn't want to do it. So what I did is I provide the mother with the lab kit, and the mom gave it to the obstetrician. When the baby was born, they sent testing. Baby was born with 6 pounds, Apgars were perfect, 8, 9, 10, no difficulties breathing or feeding. She went home with mom 2 days later. On day 7, I got the results. I brought her to the clinic and I had the discussion. Mom was obviously devastated because this was her second child with spinal muscular atrophy. Her test was same as her sister. She had a homozygous deletion of exon 7 and 8 in the SMN1 gene, and she had only 2 copies of SMN2, what it will make her a spinal muscular atrophy type 1. We talk about the treatment options, and we start also talking about standard evaluations that we're going to do. Mom knows a lot because she has already her older daughter. Let's talk a little bit about the presymptomatic treatment of SMA. What do we know from the available data from all the studies that have been done? I like this graphic because it shows the progression of the different types. So then you have a better understanding what I have been trying to say in terms of the classifications. The green line will represent what a normal person will be in terms of milestones. You're born and you start gaining milestones progressively to a maximum point where you will be stable, meaning we learn to crawl, we learn to walk, and then we continue walking the rest of our life. But then you see the orange line demonstrating a patient with type 1. This patient is going to be pre-symptomatic. Patient doesn't show any symptom, baby look perfectly normal when they are born, but by 2 or 3 months of age, they start having difficulties feeding, they start having difficulties breathing, they start breathing faster, and that's when the parents identify that there is something going on. And then you have this acute phase for patients with type 1 when they rapidly start deteriorating. So important to see that there is a window. That's why it's so important to try to identify these patients to hopefully get them before they start quickly progressing. Then you have a type 2. The type 2s will also have the pre-symptomatic time, but their progression is more subacute. So these patients will progress in their milestones because they will be able to hold their head, they will be able to roll most of the times, they can sit independently, but that's where they will get up to. And from that point on, what you're going to see is a progressive deterioration over time. They don't deteriorate fast, but they do deteriorate. Things that we see that they lose, for example, their arm function. Before they were able to get food to their mouth, but then many years later, they lose that ability. Then you have a type 3, that will be the blue line, where pre-symptomatic time will be longer, because that's why sometimes these patients are not identified but months and months later, because this patient learned to sit, learn to roll, learn to stand up, learn to walk, so pretty much look like normal kids. But then in a subacute manner as well, they will start losing those milestones. They will start getting more fatigued, they will start getting more tired, falling, and that's when things start going down and they progressively deteriorate to the point that they may lose the ability to walk. And then you have the type 4, that will be the purple line, who is a patient that really grows to be an adult. It's a patient that walks normal, everything is fine, but then very similar to a type 3, will start deteriorating in their 20s or 30s with fatigue, with falls, with weakness. Nusinersen was the first treatment that was approved for spinal muscular atrophy. This treatment was approved in December of 2016. And the treatment is really medication. It's an antisense oligonucleotide. The antisense oligonucleotide, it's going to make the SMN2 copy work as an SMN1. So it's going to make that copy work better, not only as a backup, but as a main copy. The way it does it is because it helps with the splicing of the gene. Making this gene includes exon 7. SMN1, the main gene, is not in the body. The SMN1 usually will have from exon 1 to exon 8, including all the exons from 1, 2, 3 until 8. That's why it produces 100% of the protein. SMN2, on the other hand, naturally does not include exon 7 most of the time. That's why the protein that produces is only 10%. So what is that this medication does? It goes and helps that gene work as if it was the main copy, as a SMN1, with hopefully producing higher levels of protein that is going to reflect on that anterior horn cell to be alive, with that nerve developing better and that muscle developing better. The study that I'm going to talk is Nurture, is one of the studies in presymptomatic patients. This is a phase 2 study that was including patients, 25 patients less than 6 weeks of age who did not have any symptom at that point and who I'd confirmed as SMA. 15 of them had 2 copies of SMN2, and 10 of them had 3 copies of SMN2. So as we know, 2 copies maybe is going to look like a patient with type 1, and 3 copies probably will look like a patient with type 2. They did primary endpoints and secondary endpoints. Within the primary endpoints, one of the things they look at was if the patient was going to still be alive without any other treatment, meaning without any other intervention. If a patient with spinal muscular atrophy type 1 is not treated, meaning tracheostomy, ventilation, G-tube, the patients will die less than 2 years of age. But in this case, these patients, all of them, the 25 of them, by this year, March 2019, are alive. These patients are not ventilated. They are not requiring permanent ventilation in the form of BiPAP 24 hours. They are not using tracheostomy. So we have changed completely the landscape of spinal muscular atrophy. Now you have kids that are alive, that are not paralyzed, that are not requiring any permanent ventilation, that are not requiring really, they are able to eat, they are not requiring G-tubes, they are not requiring a lot of the things that we used to do for these patients. Some of them have required intervention, respiratory intervention, because they get sick, and if they get sick, that may put them in the hospital and they may need some ventilation for some days. I like this graphic because it shows more clear what we're seeing. So out of the 25 patients, 25 of them control their head. Out of those 25, 25 can sit without support. 23 can walk with assistance, and 22 can walk alone. If I will show you the natural history of these patients, the only thing that a patient with spinal muscular atrophy would be able to do in the past would be maybe some of them will be able to hold their head a little bit, wobble their head, but they will never be able to sit, they wouldn't be able to walk, they wouldn't be able to do anything like this. And this is another of the secondary endpoints. The CHOP intent is a functional scale. So it tells you when you examine the baby, you're looking at arm movement, leg movement, head movement, and so on. And it's a scale with a score up to 64. And what we see in this graphic is that the green line are the patients with 3 copies, and the patients with the blue line are patients with 2 copies. And you see that these patients max the score. They get all the way up like any other normal child will be getting. So they get up to 64 points max score in this type of tool and evaluation. If you see the line below that, there is this gray kind of line, that will be the natural history of a patient with 2 copies of SMN2, meaning a spinal muscular atrophy type 1 patient. And you see that that patient will never reach the numbers we're seeing right now with the treatment with Nusinersen. The second therapy that was approved this year, in May of this year, it's a different type of therapy as it's a gene transfer therapy. So Nusinersen makes the SMN2 copy work better. Gene transfer therapy, on the other hand, you're really putting the SMN1 gene inside the body. It goes through an AAV9 vector, so it's an inactivated virus. The gene is inside that virus, the SMN1. It's injected through an IV. It's given through an hour infusion, and it's a one-time infusion. The sprint was including patients that were pre-symptomatic, so very similar to nurture, right? Patients that were less than 6 weeks of age who did have only 2 copies of SMN2 or they have 3 copies of SMN2. 10 of them have 2 and 12 of them had 3 copies. And this data is preliminary data, is May of this year, but this is an ongoing study, this is an active study. So we're still looking at the outcomes. All the 22 patients are alive, number 1, and 2, they do not require permanent ventilation. 6 of these patients with 2 copies can sit independently for more than 30 seconds at around 7.6 months. 3 patients with 2 copies also can stand up with assistance by 10 months. The normal child will be standing at around 9 to 10 months. So it's reaching, these patients are reaching normal milestones by the normal appropriate age. The other scale that they use, same as in the nurture study, they use the Choppington. And what we know and what we see right now is that the patients are also reaching maximum scores around 60, 64. This graphic is also important in terms of thinking, what is that we have to do all of this, or what things can we do to modify what's coming down the road? One, identifying these patients early is number one. It's what we have to try to get all the pediatricians, neurologists to try to identify patients early, because we talk about that presymptomatic time that is key to treat patients. But even if you don't treat, if you do primary prevention, let's say you do testing in the parents, you try to do carrier testing, you try to do screening testing, newborn screening, all of that will be primary prevention that can decrease the incidence of the condition. But that doesn't mean you cannot do secondary or tertiary prevention. You can also think about patients that are symptomatic already, a type 2 or a type 3, but if you treat them earlier, you're going to see modification at long term of the condition. Meaning, if a patient with type 3 is treated early, maybe that patient will not lose ambulation, and maybe that patient will not end up using a wheelchair. If you treat early a type 2, that patient may not develop severe scoliosis. The functionality of the arms may remain more stable. In the past, we have most patients identified later. Most patients really not identifying the presymptomatic or early symptomatic time, but most of them later on down with more aggressive condition. What we're trying right now is to try to identify all of those patients in the presymptomatic time, and also maybe in the early symptomatic stages, and try to treat them and try to decrease all the complications that are going to happen over time. So one of the things that is important that I will mention here is that with any of these therapies, one, you need to have close follow-up. We need to be able to bring these patients for labs. We need to be able to do physical exams. But the other thing is that we have to remember that these therapies are not the cure yet. They are changing the landscape, they are changing their prognosis, but this is not the cure, and these patients should continue having a standard of care in our clinics. This is Millie. Her clinic follow-up was actually today. I had her in clinic, and she is right now 2 months of age. She's able to hold her head. So a normal kid at 2 months to 3 months of age is the time where she'll be able to hold your head, and she's doing it. She can hold it, I can seat her with support, and then after that she can hold her head pretty well. Her sister, we never got to that point really, to that, that early response that we're having. She's not able to roll yet because she's too little, and her CHOP score jumped up pretty well. Now it's 52 out of 64. We have her on a BiPAP at nighttime only, just because we want to keep the lungs expanded. Winter is coming, so I just want to make sure that I'm keeping her in good shape. She's eating by mouth, and she also has an NG, like you can see in the picture. And the reason is because we are waiting to do a video solid study to evaluate, and if that is fine, then we can take the NG. And likely I may not end up doing a G-tube because I don't think she's going to need it. So after all of this talk and the case I present, the conclusions are mainly to understand how important the early diagnosis is, how important to try to identify these patients as early as possible, hopefully in the presymptomatic time. SMA landscape has changed extremely fast. We have Nusinersen that is approved for all ages of patients with SMA, so patients with type 1, 2, 3, 4. And we have gene transfer therapy approved for patients that are less than 2 years of age. Both of them had altered the natural history of these patients. Clinical trials are ongoing, so hopefully more therapies are going to be available in the next years. For this reason, getting diagnosis early, identifying these patients early, hopefully implementing newborn screening in all the states will be the future in this condition that is going to continue changing the landscape.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/SDE860. This activity is supported by an educational grant from Biogen.